Welcome to my education channel YouTube Surgery and Orthopedic Education. This video is next in my series of YouTube teaching video cast for undergraduate and postgraduate medical students. In this video lecture today, we are going to talk about cervical spine injury management. In the end, please subscribe to our channel and give us a like if you find the discussion useful. Also, don't forget to press the bell icon below to watch my videos regularly. Traumatic spinal cord injuries can be serious. They may cause irreversible neurological injury and patients may face devastating outcomes. Initial workup includes plain radiographs, helical CT, and magnetic resonance imaging to assess severity and management decisions. As a general rule, the spine should be protected from further injury by maintaining a strict immobilization. Patients should be transported from the scene to the emergency department with a cervical hard collar on a hard backboard. Patients must be surgically and medically stabilized before a focused neurological examination is conducted. The initial assessment should include clinical examination, mechanism of injury, and extent of the injury sustained. Treatment of spine injuries must be based on the level of injury, the stability of the spine, presence of subluxation, extent of angulation, level of neurologic deficit, and overall clinical condition of the patient. The neurogenic shock in spinal trauma presents as a triad of hypotension, either normal heart rate or bradycardia, and warm peripheries. For more detailed discussion on patterns of a specific cervical spine injury, please watch my previous video named A Specific Cervical Spine Injuries. Link is given in the description box below. Many patients with spinal cord injuries also have additional injuries. The treating team leader will initiate specific tasks according to Advanced Trauma Life Support Protocol or as per local or national guidelines. Assessment and treatment of airway, respiration and circulation should be the first priority. The patient is best treated initially in the supine position. Log rolling the patient to the supine position is a safe way to facilitate evaluation and treatment. Airway management in spinal cord injury, especially with a cervical spine injury, is challenging. The neck must be maintained in neutral position at all times. It is essential to clear oral and nasal secretions and also debris like dust, grass or cloth to maintain airway patency and to prevent aspiration. The modified jaw thrust and insertion of an oral airway may be all that is required to maintain an airway. However, intubation may be required in more severe cases. In fracture dislocation injuries, the anatomical alignment of the vertebral column should be achieved and maintained with the help of a skeletal traction using crutch-filled tongs. External immobilization of cervical fractures is done with a halo brace or a halo jacket. The shock after an acute spinal cord injury may be either hemorrhagic or neurogenic or both. A thorough search for occult sources of hemorrhage must be made. Appropriate IV fluids, analgesics, and antibiotics must be administered. The neurogenic shock requires resuscitation with volume expansion and sometimes vasopressors or inotropic therapy. The shock should be treated aggressively, particularly when there is a combination of hemorrhagic and neurogenic shock. The blood bank should be alerted in advance. Previously, methylprednisolone or solumedrol was administered to patients with acute spinal cord injury in emergency department, but the current guidelines no longer recommend steroids for acute spinal injury treatment. However, steroids continue to have a role in non-traumatic spinal cord compressions, such as in a malignant spinal cord compression. Realignment of the spine and correction of a spinal deformity through traction may achieve an indirect decompression of the cord elements. But any residual symptomatic compression or a significant hematoma may require formal surgical decompression. The only absolute indication for surgical decompression in a spinal trauma is a deteriorating neurological function. The decision for and the type of surgery is dictated by the injury pattern, level of pain, degree of instability, degree of disability, and evolving neurological deficit. In proper candidates, a spinal cord compression has been demonstrated to improve functional outcomes if performed within 24 hours of the injury.